Good morning. I'm pleased to present this talk on LV systolic function. The objectives of this talk are to discuss the value of LV systolic function assessment, to review LV myocardial architecture and how it relates to LV systolic function, and to describe methods for assessing LV systolic function with a focus on 2D and 3D LVEF and 2D speckle tracking strain. Assessment of LV systolic function has demonstrated prognostic value in a variety of disease processes as listed on this slide. This is why assessment of LV systolic function is the most common indication for an echocardiogram in most laboratories. A variety of methods have been used to assess LV systolic function. The Tycotes and Canonian methods are two older methods using linear dimensions to estimate volumes. They're no longer recommended in the guidelines for use. Rate of ventricular pressure rise and LVOT stroke volume are methods that can confirm your assessment, but they have their weaknesses and are not quite recommended as the initial assessment methods. I'm going to focus most of my talk on biplane method of DISC, which is recommended for 2D data, 3D volumes, which is for 3D data, and LV strain. Currently, the biplane disc summation method is recommended for 2D echocardiographic data. A stack of elliptical discs covering the LV are calculated using contours from the apical 2 and 4 chamber views. These discs are then summed to determine the LV and systolic and diastolic volumes and to calculate ejection fraction. As you can see from the methodology, this is why biplane LV volumes are not an average of the volumes from the 2 and 4 chamber views. Keys to successfully using this method include focusing on optimizing the endocardial definition during image acquisition and identification of the true LV apex and ensuring that there is no foreshortening. One source of variability and inaccuracies in this method is the placement of the endocardial border. Ideally, it should be placed at the compacted, non-compacted myocardial border. Quality improvement initiatives should be performed within laboratories to ensure consistency within and between interpreters. The use of semi and fully automated programs will reduce variability and improve accuracies. Normal 2D LV volume and ejection fraction ranges are provided in the 2015 guidelines. These values were derived by combining data from seven different databases. There was no core lab involved in these studies. I also want to point out that the partition values for mild, moderate, and severely dilated are provided. However, these are expert-based rather than outcomes-based. I suspect that the next iteration of the guidelines will have cutoff values that are different based on this WACE study. WACE was a multi-center, multi-country study sponsored by the American Society of Echo to generate normal echo values. It involved over 2,000 participants. All the echocardiograms were analyzed in two core labs. In this table, there is the LV end diastolic and end systolic volumes and ejection fraction data for males and females from the WACE data. As you can see, LV dimensions and volumes were larger in males than in females, while females had higher LVEFs. Also provided are the cutoff values in the 2015 guidelines, and you can see that the upper limits of normal values for the volumes are larger than that in the current guidelines and will likely trend upward in the next guidelines, as well as the range for ejection fraction is narrower, and that will probably also be changed. The WACE study also provided information on differences among races and nationalities. Here I've included a figure with each country in the study represented as a circle. The areas indicate that there's a significant difference between the values between these two countries. The base of the arrow is the larger value and the tip of the arrow represents the smaller. Here for both males and females, many countries had much larger LV and diastolic volumes indexed compared to those in India. On the right, I've given you the male and female breakdown for LV and systolic volumes indexed and diastolic volume index and ejection fractions. And across the bottom, you can see it by country as well as by white, black, or Asian race. The brown shaded area is the global WACE upper and lower limits of normal. The blue bars indicate the current guidelines upper and lower limits of normal. As you can see, that there are no differences in ejection fraction across the countries or by race. However, there are differences in volumes, with dimensions of volumes being similar for patients of white and black race and smaller for Asians and Mexican. And there are also significant national variability. I haven't shown you the national variations within the same race, but overall nationality likely should be considered when defining ranges of normal LV volumes. Overall, to summarize, the biplane dissummation method strengths are that it corrects for shape distortions. There are fewer geometric assumptions made using this method compared to linear dimensions. Weaknesses include the fact that image foreshortening can render the measurements inaccurate. It's also blinded to regional abnormalities not included in the 2 or 4 chamber views, and endocardial dropout can increase the variability due to the endocardial border placement. Ultrasound contrast should be used when 2 contiguous LV endocardial segments are poorly visualized in the apical views. This allows you to better see the endocardial border and provide you a way of measuring the LV volumes and ejection fraction. Because you can see that compacted, non-compacted border better, LV volumes tend to be larger when used with contrast. However, normal values have not been established yet, which makes it tricky to know what the values mean. Now, in laboratories with experience in 3D and in patients with images good enough for 3D data acquisition, the guidelines currently recommend that 3D volumes and ejection fractions be reported. When I think of 3D, I'm actually thinking of true volumetric analysis, although you can use 3D to guide an improved biplane measurement. But mainly when people talk about 3D, they're talking about this true volumetric, where all the walls of the left ventricle are tracked and accounted for in the volume and ejection fraction. Similar to 2D echocardiography, data set optimization is important for acquiring reliable volume measurements. You want to use the multiplane view to ensure that the entire left ventricle is within your 3D pyramid. You also want to make sure that the endocardial border definition is good in all views and that there is no dropout in systole or diastole. People generally recommend slightly overgaining the data set to ensure that you have an analyzable data set. It is also sometimes recommended that you slightly overgain the apex and decrease the gains in the basal segments to improve your quality. Your volume rates for your 3D data sets should be ideally over 20 volumes per second, although over 15 is acceptable. The reason you want to do this is you want to make sure that you don't miss the true end diastole or the true end systolic volumes, as these will affect your ejection fraction measurements. One of the problems is when you narrow your 3D pyramid to ensure a higher volume rate, you may have dropout, as you can see here, of the apical segments. One solution to this is to use the virtual apex options on some machines, which means that the beam, instead of starting at the piezoelectric array, is in the probe, and so you end up with a wider base, and this lets you get more of your LV within the pyramid without getting a large pyramid. For some data sets, you may not be able to do that, or machines you may not be able to do that, and so you may have to go to multi-beat acquisitions or high volume rate modes to achieve this. Normal 3D reference values aren't actually specifically provided in the guidelines. What's given is an actual table summarizing findings, and partly this is because there are a limited number of patients, a limited number of studies. I expect that this will be addressed as there was a 3D sub-study performed as part of WACE, and so there will be a large number of values that could be provided for the 3D data. Again, similar to 2D, semi and fully automated methods are available for analyzing 3D data. Several meta-analyses have been performed. The most recent one was published in JACE in 2019. This study showed that fully automated methods are actually more accurate compared to MRI gold standard than semi-automated methods. Additionally, they have less variability. One of the things they did sort of find a signal for is that there may actually be differences in vendors, and so for serial studies, the patient should undergo analysis by the same vendor platform. Overall, to summarize, the advantages of 3D volumetric analysis is that it avoids image foreshortening because the entire ventricle is in the data set. There's no geometric assumptions made because all the walls are seen. As serial studies have shown, that is more accurate. And it also has better prognostic value compared to 2D LVEF. Now, part of the problems is that in patients with large hearts, the temporal resolution is much lower because of bigger data sets, though technological improvements should help with that. And we don't have large normal value studies available to date. Now I'm going to focus on myocardial deformation imaging. There are two methods that can do this, tissue Doppler as well as speckle tracking. I'm going to focus on speckle tracking for the rest of this talk. This is a nice paper published in 2018 summarizing the additional prognostic value of LV strain analysis on top of LV function analysis in different disease processes. Now, in order to understand strain, we have to understand the myocardial architecture. On the right, you can see two images. The top is a cartoon and the bottom is a desiccated heart, and you can see that the fibers are oriented in an oblique helical pattern, and on the endocardial or subendocardial surface there's a right-handed helix, and it becomes a left-handed helix in the subepicardial region. This sort of results in a predominantly clockwise motion at the base of the LV and a counterclockwise motion at the apex. This opposing motion of the LV base and apex results in a ringing-like motion during LV systole. Now, if you take a slice of the myocardial wall, you can see that most of the myocardial fibers are circumferential, and the ratio of circumferential to longitudinal fibers is about 10 to 1. Most of the longitudinal fibers are in the subendocardium, most of the circumferential in the mid-myocardium, and oblique fibers are mostly located in the subepicardium. Now, when we're tracking strain, we're using speckles. Now, these speckles are formed from constructive and destructive interference of ultrasound backscatter from structures smaller than the ultrasound wavelengths. Generally, noise is filtered out, and stable speckles or kernels are kept in the image. Now, how is speckle tracking performed? Usually the block method is the most common method that's used. What happens is there's a region of interest and speckles or features are identified within that block. Then blocks are sampled elsewhere, and these speckles that match the original block as most as possible is considered where the speckles have moved. Once you know where the speckles have moved to, then you can actually calculate strain. Now, strain is a calculation, and it's the fractional change in length or area or volume. How it's calculated is usually the final length minus the original length over the original length. Now, this calculation is important because it explains why longitudinal and circumferential strain are negative values versus radial strain is a positive value. Both longitudinal and circumferential strain result in myocardial shortening, and so the end final length is smaller than the original length, and so that's why you get a negative value. Most clinically useful strain is longitudinal strain, and the remainder of this talk will focus on that. You have to understand how your lab is reporting values because they may be reporting the calculated value, which would be a negative number, or they may be reporting an absolute value, and the interpretation will be different. So normal strain is around 20%. If you have a decrease in strain and it becomes abnormal, it will go down to minus 10%. And so if you have a strain value that is greater than normal or more negative, which is minus 22, that is still within the normal range. Now, typically when we acquire images for strain analysis in our lab, we acquire them at the end of the study. This way we ensure that the heart rate is within 10 beats per minute range for all the images because this can affect your strain values. We try to do our best to acquire non-foreshortened views, and we want to make sure that the endocardial deafening is as best as it can be throughout the cardiac cycle. If you look at the series of 3 images on the left, you can see that there's a bit of diastolic dropout in the mid to apical anterior wall in that 2-chamber view. If you look at the second image from the right, you can see that that would be an analyzable picture. However, there is artifact at the apex, and so that segment would likely have to be excluded during analysis if it wasn't tracking properly. The image on the farthest right, you can see that would not be an analyzable image. The other thing you want to make sure is that your frame rate is, and depending on what you read, between 50 to 60 to 100 hertz, because this can affect your strain values. Semi and fully automated methods are available for strain analysis. This is a nice paper published in 2018 summarizing with videos as well as images the different vendor platforms that are available out there, and I've added this reference in for you. Now, when you do the analysis, you actually have to standardize contour placement and region of interest if you want to make sure that you're at the mitral valve leaflet insertion points and you're not in the left atrium. For the basal points of your region of interest, you also want to make sure that you are not tracking the papillary muscle, as you can see on this movie over there. And you want to make sure your region of interest is not too thin, in which case then you're getting mainly the longitudinal fibers and you'll overestimate your strain, and you're not too wide because then you'll underestimate it. You have to also check that your timing of end diastole and systole is correct, as this will affect your measurements, and this is especially true in patients with conduction delay. And lastly, when you're using semi or fully automated programs, to increase reproducibility, we generally encourage that the sonographers minimize the editing that they do. Most people recommend that if 2 or more segments in a single view are not trackable, then global longitudinal strain should not be calculated for that view. There is variability among those different software packages on how much a data set could be tracked. Here, the same patients were imaged by all the different vendors, and you can see using the same data set that there's variability in the tracking and how much has to be excluded. If you're training to learn how to do strain, it's recommended that you have to analyze more than 50 cases. There's a nice study here showing that whoever is learning to do strain, once you get over 50 cases, your correlation between other readers increases. You want to be able to pick up the fact that the borders are where it should be. Here's a case where the border is placed almost too close and is tracking the epicardial surface. And then here on this image, it's fixed. And you see the difference in terms of the strain values that are provided. This slide just shows the different formats that data will be presented. Usually there's a color-coded region of interest that lets you check tracking as well as contour placement. Here the peak systolic strain values are presented, as well as the regional strain curves. And there is a heat map showing the curved anatomical M mode. Additionally, there's a bullseye that can be shown showing the regional changes. Generally, the guidelines say that a value less than an absolute value less than 20% is abnormal. However, others have said that absolute values less than 16% are abnormal and greater than 18% are normal. But then this leaves this lower normal range of between 16 to 18%, which we don't know what to do. Waist did do strain analysis, and you can see that women tend to have higher global longitudinal strain values. And once again, though, you can see that in many countries, the lower limits of normal fell out of what the average were. And so interpretation of lower limits of normal should be interpreted with caution. One of the limitations of strain will depend on which generation or which version of the software you're using. But going back to that intervendor comparison that was done, you can see that there is significant variability in global longitudinal strain, and there's also significant inter and intra-observer variability depending on the package that you're using. Now, standardization of definitions for global longitudinal strain have been performed, and studies have demonstrated that after the standardization, the variability between vendors and within a vendors have actually improved. This can't be said about regional longitudinal strain. Studies have demonstrated that there's still significant differences in regional strain measurements, and this also extends to reproducibility and variability. So the bottom line on segmental or regional longitudinal strain is that there's significant intervendor bias that exists, there's high variability, and single segmental strain values should be used with caution. That being said, there is a role for pattern analysis, and the most common one we recognize now is this amyloid pattern with apo-sparing of strain. Contrast has been used to enhance strain analysis. This study showed reasonable results, although it's probably not ready for routine use at this time. Overall, 2D tracking global longitudinal strain is very 3D echocardiography can address some of these weaknesses. However, it must be noted that this is still a research tool and that there are differences among the vendors, and so it's probably not yet ready for real-time use. Lastly, I want to discuss the relationship between LV ejection fraction and strain. We've kind of talked about them as separate entities, and then there's this concept that that strain is picking up submyocardial abnormalities. What I do want to say is that there is a linear relationship between LV ejection fraction and strain. As you can see that as a strain, as this absolute strain value increases, so does LV ejection fraction. And sort of a rule of thumb is that sometimes you can multiply from this the strain by 3 to get a rough estimate of your ejection fraction. Now, what about patients with quote-unquote preserved ejection fraction? You can see that even in patients with preserved ejection fraction, there is a reduction in global and circumferential strain. Now, one of these confusing concepts is how can you have normal ejection fraction with abnormal myocardial function? This paper tried to address that, and what they did was they both used echocardiographic data as well as mathematical modeling. And what they found that you can have a preservation in ejection fraction in ventricles that have thick walls or reduced end diastolic volumes, even if your global longitudinal strain and circumferential strain are reduced. And in some cases, the reduced longitudinal shortening or longitudinal strain can be compensated as it contributes less to LV ejection fraction than circumferential shortening. And so sometimes there's a compensation by circumferential strain. In summary, 3D LVEF should be reported over 2D LVEF when expertise is available. 2D speckle tracking global longitudinal strain should be performed routinely when indicated. Care should be taken for both 2D and 3D volumetric and strain analysis during image acquisition. Training is needed to standardize analysis of ejection fraction and strain. Semi and fully automated methods will help with routine reporting and improving reproducibility. One of the things that you have to be aware of is possible intervendor differences, and at this time it's probably recommended to use the same vendor for serial analysis. Thank you.
Dear colleagues, welcome again to CSE's 2020 virtual meeting. I'm Lawrence Redsky from the Israeli Heart Center Jewish General Hospital in Montreal, and it's a pleasure to be here. Today I'll be talking to you about the echocardiographic assessment of the right ventricle. My relevant disclosure is listed on this slide. My talk has a number of objectives, including identifying all the components of the right ventricle on standardized echocardiographic views. We'll be discussing how to correctly measure RV size and dimension and identify abnormal RV dimensions and anatomy. We'll be evaluating RV function using quantitative parameters, correlating which quantitative parameters of RV size and function have a diagnostic significance and can predict clinical outcomes in select conditions, and also review the need to integrate variables to adjust to different clinical scenarios. I like to start off by emphasizing clinically how important the RV is. Take, for example, these 3 patients. Who's sicker? We have patient A, who has a significantly dilated left ventricle, 65 millimeters, severe LV systolic dysfunction with ejection fraction of 20% moderate MR. Patient B has a small LV with a normal ejection fraction and no MR. Patient C has a mildly dilated left ventricle, mild to moderately reduced left ventricular ejection fraction, mild MR. And for those who know me, the answer to all questions like this is it depends. Well, here we see the answer as always. It depends. The first patient with this severe LV dysfunction and the defibrillator wire, you can see, is short of breath because there's no stroke volume, mostly related to left-sided problem. The second patient with a small left ventricle, which is dynamic, has PAH and severe RV systolic dysfunction, so his stroke volume is similarly reduced, but this time it's related to an RV problem, so this patient is short of breath. And the third patient with the ejection fraction of 40 to 45% has severe tricuspid regurgitation. So there's decreased forward flow because everything from the right ventricle that's being pumped is going back into the right atrium and not going forward into the pulmonary circulation. So the problem with the previous scenario is they gave you no information about the right ventricle. This brings us to the first fundamental equation of cardiology, which is, in the absence of shunt, R equals L, or the stroke volume of the right ventricle is equal to the stroke volume of the left ventricle. So if the RV is not pumping to feed the pulmonary circulation, ultimately the left ventricle doesn't have blood to pump to the rest of the body, and the patient is therefore symptomatic. So let's move on to how we actually image the right ventricle. There are, as you can see, a wide variety of views that we use. We hear all about how difficult it is to evaluate the RV by two-dimensional echo due to its complex shape and its anterior position in the chest. As a result, we need these multiple views from multiple imaging planes that we mentally stitch together. Here we see the most common views that are used in our routine study. We're going to review which views are used to visualize the various walls or segments of the right ventricle. The anterior wall, as can be seen in this slide, is best seen in the two parasternal views, the RV inflow view, this is obtained by tilting the probe caudally towards the hip. This is usually thought of as a view to see the tricuspid valve, but it's also very useful to see the anterior wall of the right ventricle. The parasternal short axis also shows the anterior wall. The inferior wall can also be seen in the RV inflow view. It can be used to visualize more limited degrees of RV infarction or a more distal occlusion. The parasternal short axis view shows the inferior wall as adjacent to the infraseptum and the LV inferior wall. This view can be used to closely look at suspected RV infarction or to help distinguish between an RV infarct and a pulmonary embolism. The right ventricular outflow tract segment is seen in the parasternal long axis view and the parasternal short axis view. The myocardium of the RV outflow tract is of different embryologic origin, and RVOT function may be discordant with function of other segments. Finally, the wall that we're most familiar with, the so-called RV free wall, which is really a non-anatomic name, this provides much of the well-recognized base to apex motion that we'll cover soon. It's seen in the apical views as well as in the subcostal view. A brief word about the coronary supply to the RV. As can be seen by the various colors in the legend, the RV free wall is supplied by acute marginal branches, while the inferior wall is supplied by the PDA. The RV has a complex three-dimensional shape that is difficult to measure by 2 dimensions, but for simplicity and applicability, the RV size is best estimated from the apical window using the RV-focused view. This view was derived to account for the variable size of the RV chamber and the apical 4-chamber view depending on probe rotation. As you can see, rotation determines where you cut through the pyramid. The RV focused view ensures the greatest dimension by cutting through the so-called apex. This table shows the reference values representing 95% confidence intervals for the different dimensions that we can measure. The most commonly used measurement, as mentioned above, was the RV basal diameter, whereas anything greater than 42 millimeters unindexed to BSA is considered abnormal. Please note that these are unindexed values to either BSA or to gender. Other measurements that we use include the parasternal long axis RVOT view, which is still one of the criteria for the diagnosis of arrhythmogenic cardiomyopathy, previously known as arrhythmogenic right ventricular cardiomyopathy. Moving on to RV systolic function, we have both regional and global measures. The regional measurements focus mostly on the base to apex motion of the RV free wall. TAPSE, or tricuspid annular plane systolic excursion, measures this motion from the onset of systole to the end of diastole. What you do is you place your M mode cursor through the tricuspid annulus and you activate the M mode, and you measure from the M mode tracing the distance excurred by the tricuspid annulus from the beginning of systole to the end of systole. TAPSE has reasonable correlation with global RV function in many cases, and is also prognostic in pulmonary arterial hypertension, among others. The lower reference limit is 17 millimeters, and it's one of the preferred measurements because of its simplicity and reproducibility. In tissue Doppler mode, we can use the S primers of velocity of systolic exertion. Similarly, pulsed wave sample volume, pulsed Doppler sample volume is placed in the tricuspid annulus, and you activate and you get a pulsed Doppler signal, and note that the S prime is the systolic velocity. In the right ventricle, you have to make sure that you don't take the first spike, which is often the isomic contraction spike. The low reference limit for the S prime is 9.5 centimeters per second, so less than 9.5 centimeters per second is considered abnormal. This measurement is somewhat angle dependent, and both the S prime and the TAPSE previously mentioned in the slide before, it should be recognized only measure regional function of the tricuspid annulus, and therefore are just an estimate of global systolic function, and a poor estimate at that. Fractional area change is somewhat more global, but it also ignores the right ventricular outflow tract and some of the other segments. It's measured by tracing the RV end diastolic area and the end systolic area. So the percent fractional change is end diastolic area minus end systolic area divided by end diastolic area. You have to be very careful to trace the compacted myocardium. In other words, you can see the dotted line is deep to the trabeculation of the right ventricle, and it really is hugging the trabeculated myocardium. The lower reference limit is 35%, and it has prognostic value, but one of the limitations relates to the reproducibility because of the challenges of the trabeculations. Finally, of the traditional parameters, the right index of myocardial performance, or RIMP, is an estimate of the ratio of ejection work to non-ejection work of the right ventricle. It can be measured from the RV inflow and outflow pulsed Doppler velocities, or by tissue Doppler of the tricuspid annulus. The advantage of the latter in panel B is that it's obtained from the same beat, so our variability is less important. In either case, it's calculated as the time from closure to opening the tricuspid valve minus the ejection time divided by the ejection time. The MPI is prognostic in a number of conditions. An upper reference limit is 0.54 when used by tissue Doppler and 0.43 when used by pulse Doppler. While considered novel, 2D strain or speckle tracking or feature tracking has been in use for well over 10 years for the right ventricle. By following ultrasound speckles throughout systole, an estimate of strain can be calculated by segment. For the RV, the free wall strain is based on averaging the 3 free wall segments, but has been shown to be quite reproducible, and provides also very good prognostic value in a number of conditions. The value of minus 20% as the low reference limit is somewhat vendor specific, and there's a lot of inter-vendor standardization that needs to be published for the right ventricle. There's more data on the left ventricle in terms of standardization, but this is still a moving target. As a result, the last iteration of the guidelines in 2015 did not recommend this as a standard value, but it certainly can and should be used in specific conditions where it's been demonstrated to show prognostic value using the recommended values for the vendor that you are using. Three-dimensional echocardiography promises to overcome the anatomic limitations of 2D echo as it applies to the RV's complex geometry. While newer generation analysis software simplifies the process, there's still a significant learning curve, and the analytic packages are dependent on image quality. Published literature on AI algorithms showed limited ability for the analysis to be truly automated. It should be noted that RV volumes are smaller than those obtained by MRI, but the RV ejection fraction closely correlates to that what you get from MRI. Normal values are shown by sex and age, but in general, an RV ejection fraction of below 45% is considered abnormal. Recently, studies have demonstrated reduced survival in a variety of conditions with RVFs less than 45% and particularly less than 40%. So that was all theory, but what about in real life? Here we have 3 examples. Hopefully the one at the bottom will play. So the one at the top left corner is obviously normal. The one at the top right corner is a transesophageal echo patient on ECMO on dobutamine with an akinetic right ventricle. But one in the middle, on the bottom, it's not entirely clear. There seems to be reasonable motion of the annulus, but overall just looks a little bit off. So is this mildly abnormal or is it low normal? And this is where quantitation comes into effect. So here we're looking at the quantitative parameters applied to our unknown that we just showed you. The S prime is 9.5 centimeters per second, which is the lower reference limit. TAPC is reduced at 13 millimeters. And if you look at the free wall strain, the average free wall strain is minus 20%, which is also the lower reference limit. So you can see here the quantitation matches our eyeball, where it's either just on the border of low normal versus mildly reduced. So here we have a summary slide of RV systolic function, the parameters that are recommended by the American Society of Echocardiography. They are TAPC with a lower reference limit of 17 millimeters. We can see the limitations and clinical applications for each one of these. S prime or tissue Doppler tricuspid annulus, which is 9.5 centimeters per second as the lower reference limit. Fractional area change 35%. The MPI or RIMP, 3D ejection fraction 45%, and RV free wall strain with a reference limit of minus 20%. Which was obtained principally from one vendor. I'd be remiss if I didn't discuss a little bit about the loading conditions of the right heart. We assessed right atrial pressure using the inferior vena cava size and collapsibility. And that's a measurement of preload, but also is an indicator of RV dysfunction and is of prognostic importance. The lower left panel shows a small collapse in inferior vena cava, suggesting an RA pressure of less than 5, and in the guidelines, the number used is 3 millimeters of mercury. In the center, we have a dilated inferior vena cava, which does not collapse at all with inspiration, and this we ascribe a value of 15 millimeters of mercury. And the lower right panel shows a borderline size, borderline collapse, which is somewhere in between 5 to 10. We ascribe a value of 8 millimeters of mercury. There are a lot of caveats to this. There's some suggestion that perhaps this should be indicated to BSA with limited data in different populations. This slide is to indicate, in addition to the preload and the inferior vena cava, is to make note that the right ventricle faces the pulmonary circuit, and prognosis, for example, in pulmonary arterial hypertension is usually determined by right ventricular function. Similarly, in acute pulmonary embolism, the RV can't overcome the sudden increase in pulmonary vascular resistance and acutely fails. RV function is also important to assess when determining the need for mechanical support, whether left ventricular support is sufficient or right ventricular support is needed as well. We're all familiar with the methods to estimate systolic pulmonary pressure, most commonly using the tricuspid regurgitant gradient. We take our continuous wave Doppler of the TR jet, apply the simplified Bernoulli equation, 4 times the velocity squared. That gives us the pressure dropping to the right ventricle and the right atrium. If we add an estimate of right atrial pressure based on the IVC size and collapse, we get an RV systolic pressure. And because we're looking at this in systole, in the absence of pulmonic stenosis, the RV systolic pressure is equal to the PA systolic pressure. Just want to go through a couple of cases where the quantitative parameters don't necessarily match what your eyeball is seeing, and how one must use your integrative ability to provide an overall assessment of RV systolic function. Here we have a case of pulmonary arterial hypertension. From the upper left panel, we see severely dilated right ventricle, a relatively squashed left ventricle. In the upper right panel, we see again a severely dilated RV right ventricle. The tricuspid annulus seems to be moving quite well, but we can see that the ventricle is mostly rocking as opposed to moving inwards or base to apex. The lower left panel, we see that classic D-shaped septum with a flattening both in systole and diastole, but principally in systole. And the lower right panel is actually an apical two-chamber of the left ventricle. Because we have an apex-forming right ventricle, you can never really get a true two-chamber. And when you actually see this pattern, it usually suggests a severe RV systolic, RV enlargement. Looking at the quantitative parameters, here at the upper left, we see the RV is in fact severely enlarged. But when we look at the motion, whether it's measured by TAPC or S prime, these are in fact normal values. we all know that this ventricle looked severely dysfunctional, and if we were to calculate the RV and RV fractional area change, we can see it's severely reduced at 18%. If we were to measure strain, similarly, this would have shown a severe reduction in strain. So what this tells us in PAH, we can't rely on indices of annular motion or velocity alone to assess RV systolic function. If these are reduced, because these segments are often the last to go, that imparts a severe RV systolic dysfunction, but it doesn't pick up milder degrees. Another example of discordant values is in the post-op cardiac surgery state. If we look at the upper left panel, we can see that the base to apex motion, or the longitudinal motion of the right ventricle, is impaired. If we were to actually measure this using our TAPSE, we can see the TAPSE is significantly reduced at 12 millimeters. But if we look at our fractional area change, it's in fact at lower limits of normal. There was a nice work by Mafasenti et al. Looking at the reduced longitudinal motion, and we see that both TAPSE and S prime are significantly reduced. Fractional area change is fairly neutral. Strain is reduced, but interestingly, RV volumes and RV ejection fraction are fairly neutral, and that's because of the relationship of the septal motion. Here we can see in the upper left panel a paradoxical septal motion, and in the lower right panel you see an extreme version of this. This is a patient with virtually an akinetic right ventricle, and the entire RV stroke volume looks like it's related to that markedly paradoxical septal motion, which is acting as a bellows pushing against the blood in the right ventricle. So to summarize some key points, multiple views should be used to assess RV function. RV inflow view to look at the anterior and inferior walls, apical floor chamber to look at the free wall, and the parasternal views to measure the right ventricular outflow tract. All RV dimensions are measured end diastole. Abnormal values include RV basal dimension, the RV focused view of more than 42 millimeters, and proximal RVOT in the parasternal short axis more than 36 millimeters. There are 6 quantitative parameters to evaluate RV systolic function. These are TAPSE, S prime, fractional area change, RIMP or index or MPI on the right side, RV ejection fraction, and free wall strain. TAPSE and S prime may not reflect global RV systolic function, as they quantify principally annular motion, and abnormal TAPSE, abnormal strain, and reduced ejection fraction are associated with poor prognosis in patients with congestive heart failure, patients with pulmonary hypertension, and a variety of other conditions. When we look at a tailored approach for our interpretation, which is something that we should always consider, we have to look at what information are we looking for. Are we looking for just whether the right ventricle is normal or abnormal, in which case we have comparison to normal values derived from statistical analysis of healthy subject or populations. But there's still further value in characterizing these values with traditional parameters of structure and function. What about disease diagnosis? Are we trying to figure out what this patient has, a differential diagnosis? Is it a acute PE? Is it an RV infarct? Is it pre versus post-capillary pulmonary hypertension? Are we trying to prognosticate the patient? What is the RV systolic function in congestive heart failure, PAH, and other conditions? Are we using it to guide therapy? For example, RV enlargement and pulmonary embolism, in atrial septal defect, or pre-cardiac surgery, for example, in the setting of mitral regurgitation. So on this final slide, I would like you to draw your attention to the panel on the left, which is a Stradivarius violin. Notice the right side and left side are of equal importance. It creates notes of beauty and is very symmetric. The annotation on the right is the triple integral with a ring around it, which is a symbol to integrate complex three-dimensional volumes. I would like you to think about it more in terms of integrating 3 components when you're assessing the right ventricle. Your eyeball assessment, what does it look like? The quantitative parameters, what are you measuring? And the context in which you're assessing the patient. Is it abnormal or versus normal? Are you trying to find a specific diagnosis? And thank you again for your attention.
Hi, good morning, everyone. I'm very excited to be here today. Thanks to Dr. Chow, Dr. Liangpoi, and the organizing committee for inviting me to talk about assessment of the atria. I have no disclosure. We will start with left atrial structure, function, and physiology, why it is clinically significant to assess left atrial size and function. Then we will talk about how to quantitate left atrial size and function. Finally, we'll finish off with assessment of right atrial size and function. The left atrium is a fascinating chamber. It is highly dynamic volume sensor. It responds to stretch with secretion of atrionatriuretic peptide, which promotes vasodilatation, natriuresis, and diuresis. These effects counteract the actions of the renin-angiotensin-aldosterone system, which promotes vasoconstriction, sodium and fluid retention. The left atrium modulates left ventricular filling throughout the cardiac cycle. During the reservoir phase, beginning with mitral valve closure, the left atrium fills to just before the opening of the mitral valve, and that is precisely when we measure maximal left atrial volume. It acts as a conduit for blood flow from the pulmonary veins to the left ventricle during early diastole. It is an active contractile chamber that augments left ventricular filling in late diastole. The atrial kick contributes to about 30% of cardiac output. The left atrium acts as a suction pump that refills itself in early systole. Left atrial size is a barometer of diastolic function. Indexed left atrial volume correlates well with diastolic function grade. In this study of 147 persons without a history or evidence of atrial fibrillation or valvular heart disease, the larger the left atrial volume, the more severe the diastolic dysfunction by Doppler. Left atrial volume tells you not only the severity of diastolic dysfunction, but also the chronicity as reflected by the degree of structural remodeling that has already occurred. Left atrial volume greater than 28 ml per meter square was 87% sensitive and 93% specific for identifying the presence of diastolic dysfunction by Doppler. On the right, you can see that indexed left atrial volume also correlated well with left ventricular filling pressures as measured by tissue Doppler EE prime. The importance of left atrial volume in diastolic function assessment was recognized and included in the most recent diastolic function guidelines as an upfront criterion for determining if diastolic dysfunction is present or not. In addition to it being a barometer of diastolic function, left atrial size is a potent prognostic marker for cardiovascular outcomes. Left atrial volume has proven itself to be easily the most powerful predictor for first and recurrent atrial fibrillation, first and recurrent stroke, development of heart failure both in the context of preserved and reduced ejection fraction, hospitalization for heart failure, coronary artery events including myocardial infarction, need for revascularization, and post-infarct survival. It can predict the likelihood of staying in sinus rhythm after cardioversion and atrial fibrillation ablation. It has been shown to be a predictor of cardiovascular and all-cause death. In this study of 1,160 persons of at least 65 years of age, left atrial volume greater than 32 ml per meter square was predictive of first atrial fibrillation, first stroke, first myocardial infarction, first revascularization procedure, first heart failure, and cardiovascular death, independent of clinical risk factors, diastolic function, ejection fraction, and left ventricular mass. Left atrial volume is a potent predictor of first atrial fibrillation. In a study of 840 persons, all aged 65 years and older with no prior history or evidence of atrial fibrillation or valvular heart disease, we found that indexed left atrial volume was incremental to diastolic function grade for the prediction of first atrial fibrillation. The risk for first AFib was about 20% in 5 years if your baseline left atrial volume was 37 ml per meter square or more. What about left atrial volume and heart failure? In the Valiant trial ECHO substudy, which included 610 patients with ejection fraction less than 35% and followed for 20 months, left atrial volume was highly predictive of death or heart failure hospitalization. In fact, each ml per meter square increase in left atrial volume beyond 26 ml per meter square was associated with an extra 7% risk of death or heart failure hospitalization. On the right is a study of heart failure with preserved ejection fraction. Left atrial volume was also predictive of first heart failure in patients 65 years or older with well-preserved ejection fraction. Those with left atrial volume in the upper tertile of greater than 37 ml per meter square had a 17% risk of heart failure within 5 years. Left atrial volume is a powerful predictor of survival post-acute myocardial infarction. The larger the left atrial volume, the higher the risk of death. Left atrial volume greater than 32 ml per meter square independently predicted 3-year mortality, incremental to clinical risk factors, ejection fraction, and diastolic function parameters. Each ml per meter square increase in left atrial volume was associated with an additional 5% risk of dying. Now, I have used the generic term size, which can mean one-dimensional linear diameter, two-dimensional area, or three-dimensional volume. These are the RLC curves comparing the performance of left atrial volume in blue, left atrial area in yellow, and left atrial diameter in red for prediction of first events in 317 patients, all in sinus rhythm at baseline. The events of interest here were first atrial fibrillation, first stroke, heart failure, revascularization, myocardial infarction, and premature death. Left atrial volume was a better predictor of these events than area or diameter in this study. In most labs today, left atrial volume is assessed by 2D biplane Simpson's method or biplane area length method. Irrespective of which method, these guidelines on the right still apply. First, optimize your left atrial visualization. You need to maximize the left atrial area without foreshortening the left atrium. You want to adjust the gain to ensure best visualization of the endocardial border. You need to optimize the timing for planimetry. For maximal left atrial volume, you choose end ventricular systole, essentially at the end of your T wave on the rhythm strip, just before the mitral valve opens. But even if you don't have a rhythm strip, you simply need to scroll back and forth to open and close the mitral valve and pick that point just immediately before the opening of the mitral valve when left atrial volume is at its maximum. Then trace the left atrial endocardial border, with one border being the plane of the mitral annulus. Make sure you exclude left atrial appendage and the confluence of the pulmonary veins. The length is simply the perpendicular line from the midpoint of the plane of the mitral annulus to superior left atrial border. For biplane area length method, planimetry is the same. The length is midline perpendicular to the plane of mitral annulus. The two lengths should be less than 5 millimeter difference, as you are really measuring the same distance only from two different angles. There have been a lot of debate about using the longer, the shorter, or the average of the two lengths. We use the average. The key is to check to make sure that your lengths from the 4-chamber and the 2-chamber views are less than 5 millimeter difference. It has been recognized that the long axis of the left ventricle does not line up with the long axis of the left atrium. You need to make sure that there is no left atrial foreshortening so that you are maximizing the left atrial area for planimetry. On the right-hand side, I'm showing a real-life example of the difference these seemingly small adjustments can make. The standard 4-chamber view, without focusing on maximizing the left atrial area, provided an LA volume of 47 ml. By using the LA-centric view, making sure that left atrial area is maximized, the left atrial volume measured 67 ml. Now, left atrial volumes should always be indexed to body surface area. By the current guidelines, normal maximal left atrial volume is 34 ml per meter square or less. Note that the upper limit of each category is 7 ml per meter square more than the upper limit of the previous category. So it is easier to memorize it this way. Normal is 34 or less. At 7 is 41 for upper limit of mild enlargement. At 7 to 41 is 48, which is the upper limit of moderate enlargement. Severe enlargement is simply beyond 48 ml per meter square. There are inherent geometric assumptions of biplane left atrial volume. The left atrium is a far-field structure and is easy to get foreshortened. 3D left atrial volume had been shown to be superior to 2D left atrial volume with lower test-retest variability in a number of studies. I also want to mention that minimal left atrial volume is also a robust predictor of cardiac events, and in some studies even performed better than maximal left atrial volume. However, in our experience, assessing minimal left atrial volume is slightly more difficult than assessing maximal left atrial volume with greater inter-observed variability. So minimal left atrial volume has not been as widely adopted for either clinical or research studies. The latest automated border detection features of some machines and some programs will undoubtedly help us to assess minimal left atrial volume more accurately. Is 3D better than 2D? The data certainly suggests so. This prospective study by Victor Moravi's group included 92 patients who had cardiac MR, 2D biplane area length volume, and real-time 3D left atrial volume by TomTec, show that 3D left atrial volumes correlated with MR better, with a correlation coefficient being 0.93, which was superior to correlation coefficient of 0.74 for 2D. They also found that 2D methods systematically underestimated left atrial volume, and the biases with 3D were said to be negligible. On the right are the Bland-Altman plots, using a threshold of 34 ml per meter squared to define abnormal left atrial size for all three modalities. Agreement with cardiac MR was better for 3D than for 2D. The limits of agreement were much tighter for 3D and MR than for those for 2D and MR. Although recommended by current guidelines, adoption of 3D into clinical practice has lacked in the past because of time-consuming analysis. More recently, an automated algorithm that measures left atrial and left ventricular volumes and ejection fraction had been validated. As shown on this slide, following initial fully automated detection of left ventricular and left atrial endocardial surfaces, the software allows a user to perform manual corrections of the endocardial boundaries when needed, resulting in final 3D casts of the cardiac chambers. The optional corrections are performed in anatomically correct non-foreshortened 2D planes, showing focused long-axis views of the left ventricle and left atrium, both automatically extracted from 3D data set. The accuracy and reproducibility of these 3D measurements were excellent. This is Dr. Wendy Tsang's work. You can see here that 3D left atrial and left ventricular shells displayed on the 3D volume cropped to 4-chamber view. The contours are also displayed on 2-dimensional cut planes derived from 3D data set. The study findings suggested that automated simultaneous quantitation of left atrial and left ventricular volumes and left ventricular ejection fraction is feasible and requires minimal 3D software analysis training. The automated measurements are not only comparable to manual measurements, but also to cardiac MR. This technique is highly reproducible and is time-saving. How does 3D compare to 2D left atrial volumes for prediction of outcomes? This study of 116 patients with severe left ventricular systolic dysfunction had both 2D and 3D left atrial volume assessed. The outcomes of interest were heart failure, hospitalization, and death. They found that 3D left atrial volume was superior to 2D left atrial volume for prediction of outcomes. So in summary, 3D volume metrics when compared to 2D, based on data available, have greater precision, reproducibility, accuracy, lower variability, with no foreshortening or geometric assumptions, can now be fast and easy. 3D and 2D left atrial volumes correlate well with CT and MRI, but generally 3D performs better. Let us now shift our attention to left atrial function. This is the classic figure of 8 volume pressure loop describing the 3 phases of left atrial function that we discussed earlier. When mitral valve closes, blood fills the left atrium during the reservoir phase in yellow. In diastole, mitral valve opens, blood flows into the left ventricle during the conduit phase in orange. And at ventricular end diastole, just prior to P wave, when the atrium actively contracts during the active pump phase in blue. You can measure these phasic function volumetrically. Reservoir function is most commonly assessed as total emptying fraction, which is calculated by maximal left atrial volume at end ventricular systole minus minimum left atrial volume at end ventricular diastole divided by maximum left atrial volume. In this study of 574 patients, left atrial volume and left atrial function were assessed for prediction of first atrial fibrillation or flutter. We found that reduced left atrial reservoir function as expressed in emptying fraction markedly increased the propensity for first atrial fibrillation or flutter, independent of left atrial volume, left ventricular ejection fraction, and clinical risk factors. Individuals with larger left atrial volume, 38 ml per meter square or more, and reduced left atrial function with emptying fraction less than or equals to 49% had the greatest risk. In fact, they had a 9.3-fold increase in risk for developing atrial fibrillation or flutter when compared to those patients without these abnormalities. When it comes to assessing left atrial function, we have more than volume metrics. We can measure peak A velocity, A wave velocity time integral, atrial fraction, and left atrial ejection fraction using a complicated formula. However, all these are surrogates of left atrial function by measuring blood flow during atrial contraction, and you can only measure these when the patient is in sinus rhythm. That brings us to left atrial strain, which from my perspective is the preferred method of left atrial function assessment because it measures actual myocardial contractile function. Strain is a measure of myocardial deformation, basically the change in length divided by the original length. For instance, if we start with 10 centimeter, contracts down to 8 centimeter, the change is minus 2 centimeter. Strain is therefore minus 2 out of 10, which is equals to minus 20%. If we stretch from 10 centimeter to 12 centimeter, the change is plus 2 out of 10, and strain is plus 20%. Strain rate is simply the rate of deformation. There are 4 types of strain methods: tissue Doppler imaging, 2D and 3D speckle tracking, and velocity vector imaging. The most commonly used method currently is 2D speckle tracking, but I can foresee that 3D will become increasingly popular. Tissue Doppler imaging strain method requires high frame rate, 90 to 120 frame per second, and narrow sector angle. It is angle dependent. You can only assess strain for atrial walls but not the roof. You need to track sample throughout the cardiac cycle, is labor intensive, is susceptible to translational motion, but it can measure phasic function. 2D speckle tracking strain imaging is the most common method being used. It is semi-automated, much simpler than tissue Doppler imaging strain method. Speckle tracking recognizes ultrasound speckles during the cardiac cycle and see how the speckles move to a different location over time. It requires frame rate of 50 to 70 frames per second and is angle independent. However, it does depend heavily on the 2D image quality. This shows both global and segmental left atrial function, as well as the phasic volumes of the left atrium. The third method of left atrial strain is velocity vector imaging. It combines speckle tracking and endocardial border detection. It can demonstrate magnitude and direction of velocity. 2D images from different vendors can be used. A meta-analysis of normal strain values had already been published. The analysis had included studies using 2D speckle tracking and VVI strain methods. Strain values for reservoir function was 39% in the study, conduit 23%, and contractile function 17%. The most recent addition is 3D speckle tracking strain method. This will likely gain popularity over time because of some concerns about 2D speckles not remaining within the imaging plane and that we need 3D to track speckles independent of the imaging plane. The current problem, however, is low frame rate, non-optimal spatial resolution, and it lacks standardization. Nevertheless, recently there have been published normal values for 3D segmental strain. In this study, Camelli's group compared the performance of different atrial parameters for prediction of cardiovascular events. They found that global peak atrial longitudinal strain was superior to indexed left atrial volume, left atrial ejection fraction, left atrial area, and left atrial diameter for such prediction. Left atrial strain, and in fact left atrial function in general, is a fascinating area. As our echo capability improves over time, where strain imaging is becoming easier, it will be highly valuable in a number of areas of investigation. This study, for instance, really highlights how left atrial strain is more sensitive to detection of left atrial remodeling before left atrium becomes even enlarged. All 421 patients in this study had normal left atrial volume, but 29.4% had abnormal strain, which speaks to it being probably a more sensitive marker of left atrial remodeling. Right atrial volume assessment is simple. We use the 4-chamber view monoplane Simpson's method. Just like the left atrial volume assessment, we have to be meticulous in making sure that we don't foreshorten the right atrium. In terms of normal values for men, it is 25 plus or minus 7 ml per meter square, and for women, 21 plus or minus 6 ml per meter square. The right atrium is much less studied, but its size has been shown to be a marker for pathologies and predictive of certain outcomes, including heart failure, need for lung transplantation, cardiovascular, and all-cause mortality. In this study of 95 patients who had undergone cardioversion for atrial fibrillation, Dr. Christina Luong found that the performance for prediction of atrial fibrillation recurrence was greatest for right atrial and left atrial function, characterized by emptying fraction, followed by right atrial volume, and then left atrial volume. Although both right atrial and left atrial volume were strong predictors of atrial fibrillation recurrence after DC cardioversion, right atrial and left atrial emptying fraction outperformed in this cohort. At a cut point of 41%, right atrial emptying fraction was 83% sensitive and 100% specific for predicting success of maintaining sinus rhythm at 6 months. Left atrial emptying fraction had a similar predictive value at a cut point of 43%. Let me just summarize by saying that atrial size and function are potent imaging biomarkers. We have evolved over the last couple of decades from using linear left atrial dimension to 2D left atrial volume and now to 3D left atrial volume assessment as the technology has advanced sufficiently for us to do so. To fully characterize atrial remodeling, we should measure not only atrial size but also function. The assessment of atrial function has also evolved from relying on volume metrics to atrial strain. All this has become clinically practical because many of the previously complicated analyses have become automated on current platform. Thus, 2020 atrial imaging is all about automated precision imaging with advanced quality. Thank you very much.
Good morning, everyone, and thank you for joining us today for this Back to the Basics talk on how to assess the aorta. I have no disclosures. I will be talking about assessment of the aorta, and over the next 20 minutes, I've selected a few topics which we'll delve into in a bit more detail. We'll very quickly review the basics of aortic anatomy, then talk about the different imaging modalities available to us, with a focus largely on echo. Throughout this talk, we'll highlight some of the pros and cons of each modality, both for assessment of chronic and acute aortic conditions. And then we will close with a couple of case-based examples of some of those acute aortic syndromes. There are 4 parts of the thoracic aorta. Working from proximal to distal, there is the aortic root, which consists of the aortic valve annulus and cusps and the sinuses of Valsalva. Just beyond the sinuses of Valsalva is the sinotubular junction, which defines the start of the ascending aorta up to the brachiocephalic artery. The aortic arch is defined by the portion of the aorta from where these head and neck artery branch vessels arise. And lastly is the descending aorta, which begins just distal to the origin of the left subclavian artery and extends caudally through the thorax and abdomen. The most common imaging modalities that are used to visualize the aorta are echocardiography, both TTE and TEE, CT, and MRI. Transthoracic echo can generally provide good images of the aortic root and proximal abdominal aorta. The ascending aorta and aortic arch can be adequately imaged in most, with the descending thoracic aorta typically less well seen. The aortic root and proximal ascending aorta are best imaged in a standard left peristernal long axis view, shown in the top 2 clips, with a higher right-sided peristernal view sometimes proving more helpful for the more distal ascending aorta. The aortic arch and proximal descending thoracic aorta are best seen in the suprasternal view, shown in the bottom left. Aspects of the descending thoracic aorta can also be seen in the peristernal long axis, in modified apical views, and sometimes in paraspinal views from the back in patients with a left pleural effusion. The upper abdominal aorta is best seen subcostally, shown here in the bottom right. Transesophageal echocardiography has 2 main advantages over TTE: superior image quality and better visualization of the ascending and descending thoracic aorta due to their proximity to the probe in the esophagus. The ascending aorta is typically visualized in a modified esophageal long axis view around 100 to 120 degrees, and can sometimes be seen from a deep transgastric view as well. The probe is rotated posteriorly to assess the descending aorta, which is much better seen on TEE than TTE, at 0 degrees for a short axis view and 90 degrees for the long axis. With further withdrawal of the probe, the aortic arch and ideally the branch vessels are seen, although this can be challenging with the potential for blind spots due to interposition of the trachea. CT has a number of advantages, including its availability, rapid acquisition and processing speed, and non-invasive nature compared to TEE. Importantly, it allows imaging of the entire aorta with a 3-dimensional dataset, which allows imaging of the lumen, wall, and periaortic regions, identification of anatomic variants, such as the common origin of the brachiocephalic and left common carotid arteries represented here in the left image with an asterisk, branch vessel involvement, and distinction among types of acute aortic syndromes. Oblique 2D imaging can lead to overestimation of aortic dimensions, which can be avoided with a 3D dataset. On the right is a markedly tortuous aorta with a thoracoabdominal aortic aneurysm, and a very obvious example of how the aortic dimensions would be overestimated in a standard axial slice shown in Figure C. By aligning the dataset perpendicular to the centerline or axis of the aorta, as shown in D, we can accurately measure proper aortic dimensions. The main downsides of CT relate to risks associated with the use of contrast, and it is the one modality with radiation, although there are a number of techniques to minimize the dose delivered. CT aortography can be used for chronic surveillance scans, with ECG gating being particularly helpful to avoid artifacts that can mimic dissection flaps. These are a few examples of potential artifacts. The image on the top demonstrates a pseudo-dissection of the ascending aorta with opposing linear artifacts due to motion. The image on the bottom demonstrates a double contour of the aortic root in a non-ECG gated study that may also simulate a dissection flap. In the setting of suspected acute aortic syndromes, a preceding non-contrast CT can be very helpful to rule out intramural hematoma, as we'll see in our second case later on. And an additional post-aortogram CT can improve the detection of visceral malperfusion in dissection and distinguish slow flow from thrombus in a false lumen. Each of these scans can be acquired in seconds. MRI provides good imaging of the aorta and surrounding structures as well as functional data, with the added advantage of no radiation. However, its limited availability, lack of portability, and longer scan times than CT generally restrict its use more to chronic surveillance in certain populations. When it comes to serial imaging and comparing findings between modalities, it's important to be aware of potential sources of error. Some include where the measurement was made. For example, was the measurement taken in the proximal ascending aorta or the distal ascending aorta? Was the measurement made from inner edge to inner edge of a structure or from leading edge to leading edge? And what was the trigger timing or phase in the cardiac cycle when the measurement was made? Despite differences in image acquisition methods and resolution, echo, CT, and MRI are all near equivalent as standards for assessing aortic root size, although much of the normative data and prognostic significance of aortic dilation is derived from echo. It is important to understand what we're measuring, though. This is a zoomed-in cross-sectional view of the aortic root at the sinus of Valsalva level, measured with inner edge to inner edge CT convention. One can measure from one commissure to the opposite sinus, shown here with the yellow line, and from one sinus to another sinus, which is often approximately 2 millimeters longer and shown here in red. Measurements using the sinus-to-sinus method will generally agree closely with echocardiographic measurements. The aortic root is very well seen on transthoracic echo and is measured in a zoomed-in peristernal long axis view as the largest diameter from the right sinus of Valsalva anteriorly to the posterior sinus, which is usually but not always the non-coronary sinus. It is measured at end diastole using the leading edge to leading edge technique. It is important to know that variations in probe angulation will cut the aortic root along different planes, and so it is important to actively search for the largest diameter. If the curvature of both sinuses is well seen and the line of aortic leaflet coaptation is midline, then this will likely represent the maximum obtainable measurement. One limitation of echo that is worth pointing out is that image acquisition is inherently operator dependent, which can introduce additional variability in aortic measurements. This study looked at the inter-observer variability in 60 patients, 20 with a bicuspid aortic valve, 20 with Turner syndrome, and 20 normal controls, with their aortic roots and ascending aortas scanned and measured by 2 different sonographers on the same day. In 1/4 of cases, there was a greater than 2 millimeter difference in the measured aortic root and ascending aorta dimensions, with larger discrepancies noted in patients with established aortic dilation. This can be attributable to a number of factors influencing test-retest variability, including different cutting planes, different measurement sites, and differences in measuring techniques. A difference of over 5 millimeters was seen in 3 patients. One example is shown here on the right, where the second observer has likely underestimated the ascending aorta dimension by measuring a side lobe artifact rather than the true posterior wall. The point I want to emphasize is that in cases of large differences suggesting growth, potential causes of test-retest variability should be considered before the measurement difference is felt to reflect a true change. In terms of defining normal aortic root dimensions, the figures at the top have appeared in guidelines for a while, coming from data published by the group led by Roman back in 1989. The charts at the bottom were published in the most recent guidelines on multimodality imaging of the thoracic aorta and are what I tend to use in our lab. These tables highlight the upper limit of normal, defined as 2 standard deviations greater than the mean predicted aortic root diameter, and are adjusted for age, sex, and BSA, which can account for changes in variables over time, helping to distinguish normal from pathological growth. While the aortic root has clear landmarks for measurements, the ascending and descending thoracic aorta do not. We know that the aorta gradually tapers as we move more distally, and so in order to make comparative measurements of a structure over time, it is important to specify the location of measurements by referencing them to a given landmark if possible. For the ascending aorta, this may be the distance from the sinotubular junction to the measurement, and for the descending aorta on TEE, this may be the distance that the probe is inserted from the teeth. We will now shift gears to talk about acute aortic syndromes. These are comprised of aortic dissections, intramural hematomas, and penetrating aortic ulcers. They are distinct entities but often present similarly and can be potentially life-threatening. The first case is that of a 51-year-old male with a past medical history of hypertension and unknown family history as he was adopted. He presented to a peripheral hospital with 2 months of progressive heart failure symptoms and on arrival described NYHA Class 3 functional capacity. The physician there astutely noted his wide pulse pressure and loud diastolic murmur suggestive of aortic regurgitation. An echo demonstrated severe aortic regurgitation and severe ascending aorta dilation, and did also raise a question of a possible dissection flap, and he was transferred to our institution for further management. A transthoracic echo performed on arrival demonstrated a severely dilated left ventricle with mild systolic dysfunction. There was mild dilation of the aortic root and severe dilation of the ascending aorta, with an intimal flap visualized in the ascending aorta consistent with dissection. The aortic valve was trileaflet, and there was no pericardial effusion. On closer look, the intimal flap prolapses across the aortic valve during diastole, impeding valve closure, with resultant severe aortic regurgitation. The patient was taken emergently to the operating room where he underwent a valve-sparing aortic root replacement with TEE guidance. One TEE image is shown here, demonstrating the dissection flap with X-plane. Intraoperative TEE can be very helpful in these cases to help guide our surgeons in terms of aortic valve involvement and the extent of repair required. Aortic dissection occurs when there is a tear in the inner layer of the aorta which spreads to the medial layer, with resulting bleeding within and along the wall of the aorta leading to separation of the layers. Making the diagnosis in the acute setting is essential, as the risk of aortic rupture is high, typically occurring at a rate of approximately 1% per hour over the first 24 hours without emergent treatment. The classification of aortic dissection is important to help guide management, with common classification schemes including the DeBakey and Stanford classifications. The Stanford classification in particular is commonly used, as it separates dissections based on whether the ascending aorta is involved, as seen in these 2 examples of type A dissection on the left, or if the ascending aorta is spared, as shown in the type B dissection on the right. Surgery is recommended for type A dissections, whereas type B dissections can often be treated initially with aggressive medical management. Transthoracic echo can be of some value as the initial imaging modality, as shown in this first case. It is often the most easily accessible of the imaging modalities, has a sensitivity for type A dissection approaching 85%, and can help assess for complications associated with dissection. While a transthoracic echo can certainly be helpful if a dissection is identified, a negative study should prompt further imaging in the appropriate clinical context. For visualization of the dissection itself, we are looking for a mobile flap with motion that is independent of aortic wall motion and ideally seen in multiple views, helping to distinguish it from reverberation artifact. If possible, it is important to describe which aspects of the aorta are involved and visualize the entry and exit tears. The true lumen, which tends to be smaller than the false lumen, will expand in systole, whereas the false lumen diameter often increases in diastole. The true lumen exhibits forward flow in systole with no spontaneous contrast being present, whereas the false lumen may show evidence of spontaneous contrast or even thrombus formation. In making a diagnosis of aortic dissection, it's also important to look for the company it keeps. Aortic dilation is the biggest risk factor for aortic dissection. Concomitant aortic regurgitation can be seen due to a number of mechanisms, including aortic root dilation, cusp prolapse, flail leaflet due to disruption of the annular support, prolapse of the flap across the aortic valve as shown in case 1, or due to pre-existing aortic valve disease such as a bicuspid aortic valve. A dissection which extends to involve the pericardium can result in a hemorrhagic effusion and tamponade, and a dissection flap abutting the ostium of a coronary artery and obstructing flow can lead to myocardial ischemia and regional wall motion abnormalities. CT is typically considered a first-line imaging modality for the diagnosis of aortic dissection. When considering the ubiquitous presence of CT scanners in most hospitals and speed of image acquisition, CT is generally considered to have the quickest diagnostic time. High-quality images can be acquired in an operator-independent fashion, unlike echo, and its diagnostic accuracy approaches 100%. Here we very clearly see a dissection flap in the aortic arch, an area that may be suboptimally visualized with echo. MRI, while also highly accurate and with the added advantage of radiation avoidance, has a number of limitations in the acute setting which limit its use as a first-line modality. It is generally less available than CT, and the longer acquisition times, coupled with greater challenges in managing patients in an MRI scanning area, make it a less than ideal test for unstable patients. Here we can see an aortic dissection involving the ascending aorta in the top image, with the white arrow indicating a tear site, and the aortic arch in the bottom image. Case 2 involves a 78-year-old gentleman who had an out-of-hospital cardiac arrest and was found to be in PEA, or pulseless electrical activity, when paramedics arrived. He was resuscitated, and the decision was made to bring him to the cath lab, where coronary angiography demonstrated a 95% stenosis of his right coronary artery, which was treated with a drug-eluting stent. He was transferred to the intensive cardiac care unit, where he surprisingly remained in refractory shock with ongoing significant vasopressor requirements, suggesting that perhaps something else was going on. On repeat blood work a few hours later, his hemoglobin had dropped significantly, and a chest x-ray performed suggested a widened mediastinum. A bedside focused echo confirmed that his LV function was in fact hyperdynamic. He was felt to be too unstable to go for CT scan overnight, and so a TEE was performed. Views of the aortic valve were challenging, but the valve appeared to be congenitally abnormal and severely stenotic, and the ascending aorta was severely dilated. Esophageal views of the descending thoracic aorta demonstrate crescentic thickening of the aortic wall at the top of the images, consistent with intramural hematoma. The patient did go for CT scan the next day, with some selected images shown on this slide. In the top left, if you look closely, the pre-contrast unenhanced scan demonstrates a circumferential thickening of the aortic wall with a higher tissue density than the intraluminal blood, which is a classic finding in intramural hematoma. The corresponding contrast image is shown in the top right, where the circumferential thickening is again noted with preservation of the lumen itself. Looking at the descending aorta shown in the bottom image, one can again appreciate thickening of the aortic wall, which extends throughout the entire descending thoracic aorta. Intramural hematoma encompasses somewhere between 10 and 25% of acute aortic syndromes, and is thought to result from hemorrhage of the vessels within the medial layer of the aorta or microscopic tears in the intima. Unlike aortic dissection, there is no dissection flap noted, nor any obvious intimal tear or re-entry site. Over time, intramural hematoma can regress, persist, lead to aneurysm formation, or progress to dissection. The imaging diagnosis of intramural hematoma is based on identification of fresh thrombus in the aortic wall. It is characterized by crescentic or circular thickening with preservation of the smooth aortic lumen wall, which differentiates it from the irregular intraluminal surface of aortic atherosclerosis. The tissue density is higher than that of unenhanced blood, around 40 to 70 Hounsfield units, which relates to the presence of concentrated hemoglobin in recently extravasated blood. It does not enhance with contrast, and often the central displacement of intimal aortic calcification, as shown again here from this case, can provide additional support that the thickening noted lies within the aortic wall rather than representing intraluminal thrombus. These findings are most evident on CT and are what makes CT the typical first-line imaging modality for intramural hematoma. If CT or TEE findings are equivocal, MRI can be helpful. To sum things up from a modality selection perspective, for chronic surveillance, if we are evaluating a structure which is readily visualized on transthoracic echo, such as the aortic root or proximal ascending aorta, then it's an excellent, readily available modality to choose. Of course, there are parts of the aorta that are not well seen with TTE, and if we're interested in imaging the entire aorta, or those specific aspects not well seen with TTE, then CT is an excellent alternative. MRI may in fact be an even better option as long as it's available, particularly if serial repeat examinations are being considered in a younger individual, as it does not have the associated radiation risk which accompanies CT. When it comes to the diagnosis of acute aortic syndromes, while the advantage of each modality must still be considered, we place an even greater weight on the diagnostic performance of these tests, as making an accurate diagnosis of a potentially life-threatening condition is paramount. CT and MRI have the highest sensitivity and specificity for detection of all acute aortic syndromes, but the quick diagnostic time of CT in the acute setting is what makes it the usual first-line choice. In patients who are unstable and a diagnosis is required at the bedside, transesophageal echo is a very good option. Similarly, transthoracic echo can be performed at the bedside and is perhaps the best modality for diagnosis of complications of acute aortic syndromes, such as aortic regurgitation or pericardial effusion. But its limited ability to visualize the entire aorta often makes it more of a complementary tool. The take-home messages include the fact that we have multiple modalities available to assess the aorta, and it is important to consider the pros and cons of each, along with patient-related factors and institutional capabilities to help choose an appropriate test. For quality assurance within an echo lab, particularly when making comparative measurements of a structure over time, it is important that sonographers follow standardized recommendations for image optimization, acquisition, and measurements. For the aortic root, for example, that means trying to find a plane which maximizes the aortic root diameter and measuring using the leading edge to leading edge convention. For interpreting positions, it is important to try and standardize definitions of what is normal versus abnormal, including indexing measurements for factors such as age, sex, and BSA. And it's important to directly compare images between studies to determine if any measurement differences reflect a true change. For chronic surveillance of the aorta, TTE is appropriate for serial assessment of the aortic root and/or the proximal ascending aorta, with CT or MRI being the modalities of choice for visualization of the entire aorta. Lastly, in the setting of a suspected acute aortic syndrome, CT is typically the first-line test, with other modalities providing complementary information. Thank you.